Khalid Al-Qaffas and Dr. Waseema Ali.
Hello. First, I would like to thank Dr. Mohammed Fawzi and Dr. Ahmed Kamel for the kind invitation. I'm Dr. Waseema Ali. I work as a vascular intervention radiology in Bart's NHS Health Trust. And after we talked about the diagnosis with Dr. Najwa and we talked about the management with Dr. Khalid and Dr. Rana, let's talk about how to upscale our game regarding the practice of the varicose veins, as varicose vein here in Egypt has mainly been done with vascular surgeons. So I want to talk why we can do it better. So I'll be talking about the one-stop shop model and how. Okay. I'll be talking about the one-stop shop model for varicose veins and how we can turn the fragmented care to a patient-centered care. For varicose vein, it's the same disease, but two pathways, they are with very different outcomes. Why varicose vein matters? First, it has a significant impact on the quality of life and daily functioning. It reduces work predictability and healthcare resources utilization. A lot of people suffer from chronic venous disease in form of varicose veins. So despite clear guidance, care pathways remain fragmented, resulting in delayed treatment and poor patient experience. The one-stop shop concept, it's carried on by one clinician, ensuring continuity throughout the entire pathway journey, one visit, all assessments completed in a single appointment, one setting, integrated clinical and imaging facility, and same-day treatment. This is not a faster care, it's a better diagnosed, designed care. So today I'll take you in a patient journey for two different patients, Ms. Smith and Ms. Ahmed. Both, they noticed that they have varicose vein symptoms in the restlessness in their leg, the heaviness, the visible varicose veins. Ms. Smith will be referred by her GP after a long waiting time to the vascular surgical clinic, where she will have like a brief consultation with a surgeon, but they cannot do the diagnosis without a duplex ultrasound. So this will be required to be booked separately with the radiology department. Then Ms. Smith will go several weeks later to different department location to have her ultrasound scan done by a sonographer who will not discuss the scan with her. Then she will go back to the surgeon to start doing and discuss the case with her, then schedule her for the procedure with uncertain time frame. While Ms. Ahmed is going to a one-stop visit to see same clinician, give her comprehensive clinical assessment with STEEP classification, do the duplex scanning for her, and immediately discuss the findings and treatment decisions. For the treatment experience, we can see that Ms. Smith had 3 to 4 unnecessarily clinical visits. She needed to skip work, and the timeline for her suffering is extended from weeks to months. She needed to be anesthetized, she needed to be admitted to the hospital, while Ms. Ahmed, she had one single visit, same day. She had her clear, empowered, satisfied discussion about her disease. So, how to set up our practice? First, you need to establish the fundamental principle that makes this work. It's a one clinician that owns the entire pathway. Diagnosis and treatment occur on the same day. There's no separation between clinic and imaging facility. This is non-negotiable. Without this integration, you are simply creating a faster version of a fragmented service. First, you have to select your patients. You will be selecting patients according to clinical classification, the SEEP, C2 to C6. The patient should fit to your outpatient treatment, and your referral route would be generally through GPs, internal hospital referrals, or direct or self-referrals. I can't think about how many patients you can exclude, because even the patients with comorbidities, outpatient setting is better for them. But if they have an active DVT, require anticoagulation, maybe this would require to be admitted. So, regarding the clinical examination, you will need to take a full history taking, which us radiologists it's not our best trait. You need to check the impact on daily life, the severity of symptoms, if there is any previous DVT or intervention, and the risk factors. For the examination, it should be done standing. You should observe the varicosity distribution, skin changes, edema, and ulceration. And of course, stick to the SEEP classification. For the duplex venous mapping, as Dr. Najwa have illustrated, I want to emphasize that the patient position as a standing is a mandatory, and remember, it's a dynamic test, so do not discard the cuff compression or release with Valsalva maneuver, and categorize your reflux criteria. And do the complete venous mapping, and this would take you like 15 to 25 minutes to provide a complete anatomical and hemodynamical information. I'd like to have it in a form that it's written or illustrated on a diagram like this. And of course, do not forget to check for proximal inflow problems like nutcracker or May-Turner or pelvic source. Why this is important? You have real-time correlation with the patient. The patient can see the duplex findings, and you can explain it to the patient. This educational approach achieves several crucial outcomes. The patient understands why they have the symptoms, what treatment aims to achieve, and how the proposed intervention addresses their specific anatomy. Informed consent here becomes a genuine shared decision rather than a signature on a form. We have a lot of tailored treatment choices. We have the endovenous laser or thermal ablation, the non-thermal, non-tumescent techniques, and the foam sclerotherapy. When I think about the non-thermal, non-tumescent techniques, I'm thinking about a patient that cannot wear socks, cannot wear compression socks. So I'll reserve this for patients that have higher body mass index, while I can't find the size for socks for them. So I'll go for VenaSeal for them. But I need to check for hypersensitivity or any allergy. I had a really terrible case with a patient developing allergy from glue. And this is for the thermal ablation, very safe. And this is how the sclerotherapy is done. They can all be done in one same session. So you should have the same day procedure setup. You should have an ultrasound, sterile tray, local anesthetic, compression, monitoring equipment, and emergency drugs. And of course, your environment design, the clinic should be like in a good calm to minimize clinical anxiety, have room for patient to ambulate after the procedure. Here is me like examining a patient after the ultrasound, checking it under vein light. This is one doing laser ablation. This is laser ablation in details, checking the junction, confirming the location of the tip, then doing the tumescence with anesthesia. Slowly pulling back the catheter to start the ablation. Doing the other leg. Always be generous with your tumescence. Tumescence is your friend. And assure patient about how they will experience some edema in their leg regarding having the tumescence. For the immediate post-procedure care, you should encourage patient to early ambulate. Like I always require them to go around the clinic for 20 minutes before going home. Of course, I have a brief observation period in this 20 minutes. They are close to the clinic, so if anything went wrong, they can always come back. And always get the patient discharged with safety checks and telling them the red flags when to return to work advices and the activity guidance, like omitting the gym for 2 months at least, and tell them about the compression duration. So typically I keep it for 2 weeks, and then 2 weeks, and then they can't do it like only on day. Regarding the cost and activity impact, this has high impact on the saving cost, as there's no inpatient bed, no theater time, and no anesthetic support needed. You can see a lot of patients during your day, and you can have hundreds of thousands in saving annually while simultaneously improve patient experience. The final take-home message here is the one-stop shop model represents the future of vein care. This is not merely an incremental improvement, it's a fundamental regimen of how venous service should be. The evidence supported, the outcomes justified, the patient deserved it. The question is no longer if. We should adopt this model, but when. Thank you.
Thank you very much, Dr. Waseema, for this eye-opening presentation. Now for the last but not least,